welcome to What Now? On the threshold of life, death, and grief. I'm here in the studio with my friends and colleagues.
David Kennedy.
And Red Keating.
And I'm Julie Brown. And today we are delighted to welcome a guest, Dr. Charles Hayter. We're going to talk about his book, very interesting book he's written, and his life and long career as a radiation oncologist. Welcome, Charles.
Thank you. Delighted to be here.
It's wonderful to have you here. I'm going to do this official thing we do, which is read your bio, and then we're going to jump in and have some conversation. So Dr. Charles Hayter is an oncologist, medical historian, and award-winning playwright who identifies with the 2S LGBTQI plus community. He is a former associate professor of radiation oncology at the University of Toronto. His interests include medical history and the use of story and drama to illuminate medical practice. We certainly saw that in his book. He is a former president of the Canadian Society for the History of Medicine. His plays include Radical, about Toronto's Dr. Vera Peters and her quest to disrupt medical hierarchy. His most recent book is Cancer Confidential, Backstage Drama in the Radiation Clinic. It was published by the University of Toronto Press in 2022. So welcome, Charles.
Thank you. Thanks for the lovely introduction. Can I add something? Vera Peters, the subject of my play Radical, her daughter is a very prominent physician in Peterborough, Dr. Jenny Ingram.
Oh, yes, we all know Jenny.
Yeah, yes,
Right.
yeah. So she's been a big supporter of that play over the years.
Wonderful.
You just never know. You just never know.
know.
Yeah,
Yes,
we all know
Jenny.
Mhm.
Yeah.
Right, yeah.
Thank you for making that connection for us.
And the connections just keep coming. You also had a play at Fourth Line Theatre, you were telling us?
Yes, back in 2010, my play El Dorado Town, which was about the radium and later uranium refining plant in Port Hope, and the sort of legacy that it's left in the town with the contamination and whatnot.
So your impact is felt in many different areas
Yes.
of the world,
Yeah.
and I think that's a neat place to jump off with our first question, is that you do have such an interesting background, a career in drama, a career as a radiation oncologist. Can you tell us a little bit about how that leap got made? I mean, you were a drama major, and then all of a sudden, what people would think that would be a rather large and strange and curious shift in career path.
Well, I guess it was, yes. Although to me, living that experience, it didn't seem so odd. Part of the reason for that is that I come from a very medical family. My father and grandfather were both physicians, and you've probably, if you've read the book, you will have encountered both of them and a bit of their background. My grandfather practiced in colonial India. So medicine has sort of kind of always been in my bones, as it were, given my family. But I was also very interested in the arts growing up and in university. So that's what I pursued initially. People ask me how did I make that transition as you just did. I think part of it was that it was sort of luck that when I applied to medical school, way back, whenever it was, like in the late 70s, medical schools were starting to open their admission requirements. There was the first kind of recognition that people that had just studied science in preparation for medical school didn't necessarily make the best doctors. So I was lucky enough to apply to medical school when medical schools were starting to take an interest in sort of unconventional applicants. So there was a kind of a window of opportunity for me. In terms of the transition, in terms of subject matter, it was hard because I really hadn't studied any science since I'd been in high school. But the interesting thing was, and I don't mean to put down science teaching or medical school teaching, back then when I went to medical school, a lot of it was still based on rote learning, memorization of facts, multiple choice questions, that kind of thing, which, believe it or not, I found fairly easy compared to what I've been doing in my graduate work in drama, which was much more about reading and interpretation and analysis. So the first parts of medical school, actually, I found comparatively easy compared to doing my master's in theater, because it was just, part of medical school just involves acquiring this vast collection of facts and knowledge and descriptive terminology. So that's, I think, maybe tells you a little bit about the transition. On a much deeper level, as you've probably read in the book, I think now in hindsight, my decision to enter medical school was based on a need to try and connect somehow with my father, who had been quite absent from my life as a boy and as a teenager, because he was so preoccupied with his own career. So to go to that kind of psychoanalytic level, if you want, I think that was behind it as well. Something that I perhaps did not recognize completely at the time.
Right.
Yes, and I think, a lot of us can appreciate that, Charles, in terms of our actions and not really understanding the motive behind them. But it's amazing. Thank you for that. And that comes through in your book. And I just want to begin perhaps with a little comment about that. And as Julie mentioned, we have, all three of us, just really appreciated your book. And I know I when I first got it, I couldn't put it down, and I had read half of it in one evening, and I texted both Julie and Red and said, "You guys are going to really enjoy this one." And thinking about it, I realized that one of the things I appreciated was the way in which it was put together, and I loved the way that you kind of went from the two players. I mean, there's a lot more than two, but the idea of, a chapter on the frightened patient, and then there was one on the uncertain doctor, and then the disobedient patient and the ornery surgeon. And you kind of wove those stories together along with your own personal one with your family. But why was it important for you to have both of those perspectives in terms of the physician and the patient when we come to look at this challenge of cancer and oncology?
Right. Well, I think it was, for me, it was very important to put the physician's perspective in, particularly the emotional aspects of dealing with cancer patients, because I wanted to, to use a theatrical analogy, I wanted to kind of take the professional mask off and show that, we are oncologists, any physician really, are human beings. And the kind of scenarios that we see playing out with our patients and their families have an impact on us, So, there's that chapter where I have to disclose bad news to a lovely patient who is with lung cancer, who's developed brain metastases completely unexpectedly. I didn't want to shy away from depicting the anxiety that certainly and I know many of my colleagues go through before they have to give bad news to a lovely person like that. So that's what it was all about, was sort of taking my own mask off and revealing the humanity underneath. I mean, I should add, I guess, that all of the stories in the book are based on real situations. I fictionalized the patients. I made the patients really into characters because I wanted to protect the identity of the original patients. But the situations are all real. I mean, I actually did have, in fact, several patients where I had to break bad news to them, and I felt very anxious, nervous about doing that, because it's some of these pieces of bad news are devastating.
That's reminding me of the imagery of the puppeteer. You often refer to the potential or surgeons as the puppeteer. And I'm wondering if you could speak to that a little bit more, because to me, it sounds like the puppeteer has a mask on potentially, that for me, there's that sense of control and distance from the action. Yes. in the role of puppeteer. Yes. So can you speak to that a little bit?
Well, I think in many ways, doctors think of themselves as puppeteers, perhaps controlling and managing. That is, of course, is a very common word that's used in medical care, the management of patients, managing this patient. And I talk in the book a bit about how, that management is often based on protocols, scripts, if you like. And of course, what happens in practice is we like to think of ourselves, or we're trained to think of ourselves as those kind of puppeteers who can just manage patients from the diagnosis through the treatment to whatever the outcome is. But of course, humanity gets in the way, and you see this kind of struggle between wanting to be a puppet and treating your patients like as if they were puppets of you. But emotions get in the way. The patients, of course, don't always agree with being treated like that. So, I think my observation is that physicians have sort of two reactions to that. They either become more of a puppeteer, in other words, they detach themselves even more from the situation. There's a section in the book where I talk about hand puppet physicians, and I've experienced this in my own dealings with healthcare, where the doctor just kind of opens the door, comes into the room briefly. How are you doing? Everything okay? Here's your lab results, and then they disappear. And there's really no. There might be a very perfunctory attempt to say, "Oh, you got any questions?" But the question is asked in such a way that you're sort of being told, "No, don't ask me any long or complicated questions." So that it's either that physicians kind of retreat to that kind of behavior, or the opposite. The physicians that have really stayed in touch with their own humanity will engage with the patient on a deeper level than just being a puppeteer, if you like.
I mean, we so often hear about from our clients when they meet one of those puppeteering physicians, and then when they meet someone who maybe leads a little bit more with their humanity, and how that can change for them their course of treatment just by being treated more humanly and by being treated like a person as opposed to a diagnosis or a tumor.
Yes.
Right.
Yeah, I was just thinking about, we're very fortunate in our Peterborough area. We have a group of phenomenal palliative care docs, and sometimes you see that when that transfer of care really gets picked up by our palliative docs, who absolutely lead with their humanity, sometimes you just see the whole stress in the person, in the family, just come down, because they just feel there's like that. There's like all this competence behind that, like the medical competence, but then when they just feel connected, they feel connected and cared for by those physicians. And that's not to say they haven't had others along the way. I'm not trying to say that. It's just that this is the group of physicians where I see this real impact for our clients. Yes. And what a quality of life impact that can have.
Right. And I think you used a really good word, connection. And I think the last few paragraphs of the book, I make a plea for doctors to try and connect authentically with their patients, to not be scared of revealing their own humanity, I think that's where the true connection comes, is the doctor, your palliative care doctors who are brave enough to actually reveal something of themselves with their patients. Yeah.
And that raises an interesting point for me anyway, Charles, is that, and in the book you do refer to this, but the reality for the three of us in our working careers is that we were, in most cases, dealing with people who were engaged in palliative radiation, let's say, as opposed to the curative radiation. And you do bring that out in this one particular episode in your book where you're late at night and you had forgotten to do some charting and things, and you struggled with whether to take the easy route and just click the palliative radiation versus curative. So maybe help us know what the difference is. Like, what does that mean in terms of a shift medically? What does it look like for someone to be moved from a curative radiation to a palliative radiation?
Right. Well, it really boils down to the extent of the cancer and what other treatment options there are for the cancer. So in general, but this is very much in general, when cancer is spread from the organ where it starts into other parts of the body, the intent of treatment in most situations is palliative, because the cancer is not, again, I'm speaking very generally, there are exceptions to this, but the cancer is not curable. So the intent of treatment at that point is palliation, which palliation essentially means relief of symptoms and perhaps prolonging life, and above all, improving the quality of life for that person. So that's when we use palliative radiation. And the most common scenario is using palliative radiation for relief of pain from cancer when it's in the bones. You know, radiation therapy is actually a very old discipline. Like it's way older than chemotherapy. It dates back to the early years of the 20th century, after the discovery of radiation in discovery of X-rays in 1895. It was observed that it had these effects on tissues, on malignant tissues, cancers, and in particular, it was observed that if you gave radiation to a bone with cancer in it that was causing pain, it very quickly got rid of the pain. And it's something that's still not universally remembered by family doctors and palliative care physicians, is that a shot of radiation, and you can do it with a single dose of radiation, will relieve pain. And the important thing to me about that is that it allows the person's painkillers to be reduced, because a lot of cancer patients, as you probably know, are often on very high doses of narcotics. So that's a little bit about what palliation entails. On the curative side, and I think the curative side is something that needs to be emphasized, because there is one of the myths surrounding radiotherapy is that it is something that's only used for palliation. I can remember this, that patients are often kind of freaked out when they're told they're being sent for radiation, because they interpret that as meaning, oh, I'm dying, and they're sending me to radiation, which is sort of the last resort. But actually, if you look generally at the statistics, if you look at all the patients coming into a radiation department for different reasons, palliation or cure, it's about a 50-50 split, or it was a 50-50 split. I don't know. I don't have the up-to-date statistics. So 50% of patients in a radiation department are being treated palliatively for symptom control, but the other 50% are being treated for cure. In other words, to eradicate their cancer so that they live a normal lifespan. So just because you're being sent to the radiation department doesn't mean that you're dying, or that you're being treated palliatively. And it really does go back to the extent of cancer, right? I mean, if cancer is one way of thinking about radiation is that like surgery, it's a precise form of treatment that's directed to one part of the body. So that if cancer is just localized to one part of the body, it can be curative. And the best examples of that are cancers in the head or neck region, particularly cancer of the larynx, where the alternative would be to remove the larynx and all the complications that ensue with that for the patient. But radiation can cure laryngeal cancers and allow people to preserve their voice. And the same exists at the other end of the body, the anus, where removing a tumor in the anus would require a big operation, likely lead to the patient needing a permanent colostomy. But anal cancers of a small size can be cured with radiation, often in combination with chemotherapy.
How did it impact you personally when you had to, when you realized that no, we have to move this to palliative, and do you see that in any way, or do you feel that physicians feel that is somehow a failure to be able to do what you should be doing?
In terms of moving somebody to you mean a patient that I've already seen,
Right, right,
and the disease has progressed and they're really shifted to palliation.
right.
I mean, that of course is a very difficult juncture
Mm-hmm.
in the patient's journey and in the doctor's journey with the patient, because generally, and of course, here at this point, we go into the immediate association, people's mind between cancer and death and mortality. So that juncture of moving somebody or a patient moving from a curative scenario into a palliative scenario, you're really entering the territory where the patient is terminally ill and is confronting death, confronting mortality. So it's a very fraught moment, and I think I talk about that towards the end of the book when I talk about this triad of uncomfortable subjects that are not very well prepared for in medical school, and the three of them are. And what I mean by that is subjects that doctors have difficulty discussing with patients. Number one is a cancer diagnosis, but number two is relapse. Is a relapse of a cancer, when a patient might be moving from curative into palliative, and that's a difficult moment and a difficult thing to explain.
The book, while being very kind of entertaining, interesting to read with this kind of backdrop of like the different characters in a play, also brings forward, as you say, that humanity around connecting with patients and some of the struggles of that. And one of the things that I really appreciated that you wrote about, because I spend so much time on this with clients, I'm just going to read out a few sections on page 89. You said, there's also the suggestion that the patient is to blame for his cancer. And then later on, you said, attitudes like you brought it on yourself mentality that still pervades attitudes to cancer and causes needless and undeserved guilt and shame among patients. I really appreciated that. I appreciate that as somebody who myself has had my own cancer journey. It is a very common theme that comes up for people who've had cancer, or who I even spoke to someone yesterday who was doing a cancer screening, and they said, well, I think I've lived the right, I do the right things, I live the right way. And it's this attitude of thinking if we live the right way, that, we're kind of bulletproof. And those of us who have cancer or have been diagnosed with cancer, then that we've done something wrong.
Mm-hmm.
So I appreciated you kind of speaking to that.
Well, that's something that, like you, I've observed a lot in my practice, and I think it has quite a deep roots in our culture. When, as you mentioned at the outset, I've also been a medical historian, and I've studied the history of cancer and the history of radiation treatment and written about it. And one of the things that's very obvious in the early days of sort of cancer awareness, which is really the 1920s and 1930s, when governments and other organizations were becoming interested in raising cancer awareness and talking about prevention and early diagnosis. One of the common things that you see in all that literature is that cancer is somehow associated with, I think the phrase that one doctor used was dirty living, that, obviously smoking, but other aspects of dirty living, that you were, you weren't being hygienic, and you were, so somehow you brought this on yourself. And I think that was a very strong theme early on. And I think, like a lot of these themes, it's kind of like, I suppose it's a bit like intergenerational trauma, right? We're not really aware that it's there, but it's still there. Our grandparents or our great grandparents might have been brought up with those attitudes. So I think that, yes, I think there's a lot that we can still do to kind of counter that idea. People have brought it upon themselves. Of course, we know that there are a lot of cancers that are related to lifestyle choices. I mean, the most obvious is smoking, where the evidence is clear that it leads to cancers in not just the lungs, but other parts of the body. And I think, I've talked to people involved in lung cancer support, and it's a very strong feeling in that group of patients, that they should have stopped smoking like 20 years ago, 30 years ago. Why did I keep smoking? And that sort of thing.
Yeah, and and even to that, I sometimes say, like, those of us who don't smoke, I've never been a smoker, but I do, to the extent that I can understand just how powerful of a drug it is. And when they say, well, why didn't I stop? Probably because they didn't feel like they could. Right. So it's like, it's a very powerful drug in people's lives. And it just speaks to it's just not that simple. Why didn't you stop and you kept smoking? It's like, and we know there are reasons people smoke, and sometimes that has to do with other issues as well. And I just think that even if, okay, they did keep smoking, that doesn't mean they still don't deserve our compassion and the same treatment and approach, and that guilt, the shame of that in no way serves them or their family or anyone at the point of diagnosis.
Exactly. Yes. Yeah. You just have to move on, and with whatever treatment is available and possible, and not allow yourself to sink into this pit of guilt and shame. Yeah. And of course, we're talking about guilt and shame. You probably read in my book, there's quite a strong theme of people not wanting to talk about a cancer diagnosis, even setting this whole issue of lifestyle and bringing it upon myself aside. There still is this secrecy and stigma around it, which I think is because of something I mentioned before, of this. And again, it's historical, this association between cancer and death. And that's why I brought the figure of death into the book, and actually personified death, and had her flitting around in the background.
We all appreciated that character and how you brought that concept and that dynamic into the stories that you were telling. But I don't want to spend a whole lot of time on the shame game, but and guilt. But there's also another powerful point in the book where you talk about how the language of medicine says the patient failed the treatment. And so if I'm feeling the shame and the blame for my lifestyle maybe and development of cancer, there's at the other end, if the treatment doesn't work, the blame is then also sort of shifted back onto the patient for not passing but failing the treatment.
Very common to hear that from my colleagues at conferences and rounds, where they'd be talking about a patient and say, well, this Mrs. So-and-so has failed her chemotherapy, or Mr. So-and-so has failed his radiation. And of course, it's the other way around, right? It's the medical treatment that has failed to cure or treat the cancer. And I think it's just a way that doctors have of sort of deflecting the responsibility, often unconsciously, I think, deflecting the responsibility away from them and away from the limitations of medical practice or medical knowledge. There's only so much we can do in some situations. And failure is a difficult thing for many doctors to accept. I mean, I had a hard time I had a hard time with it as well, because again, certainly when I went to medical school, it's all about treating people. And, you have this disease, you give this treatment, and somebody's going to get better. That's the kind of formula. But then when you get into practice, you realize that not everybody gets better. It's not just getting better from the disease, it's also that some people get really bad side effects from the treatment. And as you know, there's a chapter in the book about a patient that I treated with radiation who got a really bad side effect. Again, I think there needs to be more done in terms of educating physicians to deal with failure, whatever that means.
Whatever that means. And I think, and we've certainly had this discussion many times between the three of us, but also it's come up in different podcasts, how the whole idea of death being failure, when in fact, every one of us are going to succeed at it.
Right.
And so coming to that whole, even to begin with the idea that death is failure for people, takes away the reality that when we get there, and I used to love that when I would have a conversation, somebody coming into hospice saying, you're coming in here to die well,
yeah.
whatever that means. And so when you die, I always think you succeeded. It's
Right.
not a failure at what you do, but the whole medical piece. And I agree with you that we need to diagnose, we need to treat, and then cure. And so people have this, that no matter what is going on with them, that, okay, I just need to see the doctor. I just need to get that radiation and everything will be fine.
Mm-hmm.
And in many cases, it can be cured, thank God. But also the reality in the midst of all of that, even if you get cured today,
Mm-hmm.
you're not going to live forever. So our mortality is part of who we are. It's not the enemy of that. But that's a whole philosophical discussion. But it impacts everything we do, and I think especially for physicians, it impacts how they approach both their work and their own sense of success in that.
Well, of course, death. When I went to medical school, there was no discussion of death. By the time I became a professor at Queen's, the medical school did have an elective, but it was just an elective in death and dying for medical students, where they would go out into the community and meet somebody who was terminally ill, and then come back and have a sort of debriefing seminar. But death, of course, is the foe of physicians, right? That's why I always loved that engraving that I had in my office that showed the physician with the radiation machine and the figure of death being kind of repelled by the radiation. Listeners can look that up online. It's an engraving by Ivo Saliger, Siliger, who was an Austrian artist, and it's called The Physician of the Rays. And it's just a wonderful image that encapsulates that struggle between doctoring and death. But of course, you're absolutely right. We're all going to die. We're all going to die. And in many respects, this may sound a little strange, but cancer patients are quite fortunate in that they have confronted, through the cancer diagnosis, they've confronted their own mortality. And as you probably know, there's lots and lots of writings about how when people are diagnosed with cancer, it's often a turning point in their lives that makes them live more fully, more presently, to enjoy and embrace life even more. So it's a curious irony that a diagnosis like that can actually make people live more fully.
Mm-hmm. Well, it reminds me in a previous episode with Vinnie Ferraro, when he quoted, I can't remember who he quoted, but the quote was something about, when we're running away from death, we're running away from life. And when we are more aware of our death and we turn towards it, we live with an awareness that our time here is limited, then it does help us live with an awareness of the preciousness of the time that we have.
Exactly. Yes.
Yeah.
And I saw that in many of my patients,
And I think that's the character of death in your book sort of illustrates that so wonderfully, because you have a relationship with that character. You and that character talk to each other and have discussions, and he challenges you and you challenges him or her, like you said. And that dynamic of seeing death as an actual figure in your life, and one you have a relationship with, I think was really powerful, because it put
Right.
death as a central character to life. I know there's
Well,
nothing to
thank
say
you,
about that,
thank
but it
you.
was really
It's
well
very
done.
interesting. That's the part of the book I
But
was the
there's
most nervous about, because it kind of took the book in a slightly different direction, in terms of something fictional, something fantastical, whimsical. But I've had nothing but positive comments about it, even though I was very, very, very apprehensive about it in terms of the writing and the style of the book. So it's good to hear that.
Something else. There's another character in the book, and it's the family, and that dynamic of the family that comes in at the last minute, and the struggle that they have, and how they push the system, the medical system, to maybe override the wishes of the patient, or contradict and challenge the medical system. And I'm wondering if you could speak to your experiences about that, because you also had that same challenge yourself with your father when he was going through his treatment.
It's a very common scenario, I think, that most oncologists, maybe a lot of other physicians, can recognize, and that is when they have a relationship with a patient, and a plan has been formulated for how the patient is going to be cared for, and then everything seems to be moving along that path very smoothly, and then suddenly, out of the blue, a family member appears. Could be a parent, it could be a sibling, it could be a child, and wants to disrupt that whole trajectory, if you like. It's a very difficult situation to deal with, and that's why I think at least 2 of the chapters in the book focus on those kind of scenarios. And you probably remember the most memorable one for me, and it's based on a true incident, was where I was kind of bullied into reversing the DNR order on a man who was dying of metastatic cancer. And it was only through the appearance of the intensive care doctor, who said this man is not a candidate for the intensive care unit, that I was able to flip back again and point out that, resuscitation would, in this situation, would just be futile, and in fact harmful. It would just lead to more suffering. And then you're right. I mean, I recognize that same impulse in myself when my father had his cancer. I was living in New Brunswick at that time. He was in Calgary, and I wanted to, get on the plane and go out there and, see what was going on and make my own recommendations. And are his doctors really competent? Do they have the most up-to-date knowledge? I never really acted on any of that, other than to give my parents' suggestions. But I could recognize in myself the impulse that I saw in those children in families that I was dealing with.
Yeah, I was thinking about that, and David and Red, I meant to ask you this. As I was reading the book, and the different chapters are different kind of characters, and I was trying to think, like, so which one am I? Am I the interfering child? Would I be the pushy patient? Because we can see ourselves, and I can see the people that I work with in it. Like, the way you organize it by these different characters, these stories that tell a story, just to me spoke to the universality of how, we're all more similar than we are different. And I've seen different variations of this in my practice as well, and in myself, in my own family.
Right.
Yeah.
I'd definitely be the confused patient. The forgetful patient.
Would you be the disobedient one, the disobedient patient chapter, David, or? Just kidding.
Ouch.
I think with having you here with us, Charles, I think it's also important to say, I want to ask some questions, just about, I'm thinking about people listening who might be being told for the first time, you've got a cancer diagnosis, you're heading for radiation, we're going to treat with radiation, what it's like for them. And so what are some of the most frequent questions you get when you're asked about radiation and what it is and how it works by patients?
Well, I often get very basic questions like what is radiation? One of the common things that happens is that people confuse radiation with chemotherapy. I have to explain that, chemotherapy are generally drugs that are given intravenously or by mouth or some other means. And it's a systemic treatment. It goes through the whole body. It may affect the cancer in one area, but it's going through your blood. It's affecting cancer wherever it is. Whereas radiation, like surgery, is a local treatment. It's given generally by a beam of radiation that comes from a machine. This day and age, mostly machines called linear accelerators, which produce very powerful beams of radiation, electromagnetic energy that is so strong that it has the ability to disrupt the DNA in the cancer cells and prevent the cancer cells from dividing. So that's one key thing that I often have to clear up, is that the radiation isn't going to go through your whole body. It's only going to affect the part of the body, the tissue that it's being directed at. So the side effects are going to be from that organ being radiated. And of course, the tissues nearby. So a very common example is somebody being treated for lung cancer. The beam will be targeted at the area of the lung where the cancer is, but there's a very sensitive organ right next to the lung, the esophagus. So one of the common side effects of radiation to the chest will be trouble swallowing and painful swallowing that might last for 2 or 3 weeks after the treatment is over. So that's one of the common questions. The other thing is, how is it done? Well, in general, so I'm going to use some technical terms here. Hope you don't mind. We call it teletherapy and brachytherapy. And teletherapy just means treatment from a distance, and that's using beams that are targeted on the tumor, the part of the body that we want to treat, from outside the body. Brachytherapy means treatment at a short distance, and that's where we put radioactive sources directly inside the body, either directly into the tumor itself or into a body cavity like the vagina to treat cancer in that vicinity. Most common brachytherapy that people have probably heard about is the use of radioactive seeds to treat prostate cancer. And those seeds are often permanently implanted. The radiation decays relatively quickly, and they become completely inert. So those are a couple of the questions, like how is it done? What's the difference between chemotherapy? What are the side effects? Common misconception might be, say, that you're giving radiation to the pelvis. Is my hair going to fall out?
Right.
Well, of course, your hair is not going to fall out from radiation to the pelvis. Your hair might fall out if we're giving radiation to the head, to the brain, or to the scalp.
Yeah, because I think it's a mystery, right? If you've not experienced it, you don't know really what you're getting into.
Yes, and it is a mystery because partly because physicians really receive no exposure to it as undergraduate medical students. I was very lucky to go to Queen's at a time when all medical students had a 1 week rotation in the radiation oncology department. And that explains why Queen's is actually overrepresented in the radiation oncology community in Canada. But that's long disappeared. So a graduating medical student, a graduating family doctor will have basically the same awareness, knowledge of radiation therapy as a patient might have. So often some of these myths and misconceptions are carried along by patients, physicians outside the cancer clinic. I think radiation oncology, radiation therapy needs to do a much better job of educating other physicians and the public about it. Particularly that I mentioned this before, the whole use of palliative radiation, which sometimes even palliative care doctors are not aware of. They've got patients who are struggling with pain, who are snowed from huge amounts of narcotics, and their pain could often be very quickly relieved by palliative radiation.
Yeah, I had a situation like that many years ago with a client, and I learned that lesson where I think we all thought this person was very close to death, just the intensity of their pain and how limited their life had become because the pain was so excruciating. And it was a palliative care doc who came in and said, we're going to do this very specific procedure with radiation because you are dying from cancer, but you're not actively dying right now. It's the pain. And this person went on to live for several more months after that with the pain so much better managed. And that was certainly a lesson for me, watching that and watching how significantly things changed for this person.
Yes, yeah. It can dramatically improve quality of life. We're not talking about length of life, but the quality of the patient's life. It is tied in with another aspect of radiation oncology, is of course because radiation therapy requires this enormous investment in technology and human resources that there's only in Ontario at least, there's only a few radiation centers. There's certainly more than what I trained. So in order to receive palliative radiation, a patient has to travel to the radiation center, and that may be difficult or uncomfortable for them.
Well, I really have appreciated our time here, Charles, and I think that I'm walking away with a number of things. I'm sure we'll have a good debrief after, but the recognition of radiation oncology as a tool, as a part of the piece of the whole picture, and how important it is, but it's not in isolation of everything. It's a part of that whole treatment approach, but it's also the importance of that being led with our humanity and that connection with people and the bigger idea of how this all works towards our treatment and helping and involvement with people along the way. So I certainly thank you. I thank you for the book, but I thank you for our conversation today, because I think it has just really affirmed what, about you that I picked up from the book. So it's been a delight.
Well, thank you very much. I think your comment loops back to the earliest question about how I got into radiation oncology. And it wasn't something that was even on my radar until I did a summer placement in the Cancer Center in Kingston. And I worked with this group of physicians who are just amazing human beings. And instead of being those kind of geeky, technologically oriented people that I expected them to be, they were not. They were just wonderful human beings who spent a lot of time with their patients, talking to them, listening to them. And that was one of the factors that drew me into the field, because I didn't see that everywhere in medicine by any means. So thank you very much. It was a wonderful discussion. I'm so glad you enjoyed the book.
Thank you.
It was a great book.
Yeah. And one more time, we'll just give a shout out to it. Cancer Confidential, Backstage Dramas in the Radiation Clinic. Thank you, Charles.
Thank you.
Thank you.
Thanks.
Thank you for listening to What Now? On the Threshold of Life, Death, and Grief. What Now is produced in partnership with Hospice Peterborough, dedicated to providing compassionate care and support to individuals and families facing life-limiting illness and loss. What Now is recorded at Thin Spaces Studio in Peterborough, Ontario. Special thanks to Paradise Garage for providing the music. Technical support is provided by Sean Hayter and audio engineering by Kevin Fleming. More episodes of What Now are available for free on most major podcast platforms. If you found value in our conversations, please support us by following the show, leaving a 5-star review, and sharing it with your friends and loved ones. If you'd like to support the essential work of Hospice Peterborough, please consider visiting hospicepeterborough.org/donate. Your contribution helps us continue to provide vital care and support. Until next time, May you find peace and comfort on your journey.